Welcome to this explainer on female sexual disorders. I'm a psychiatrist, and in my practice, I see so many women who struggle with these exact conditions every single day. So my goal today is to give you a clear, comforting roadmap. We're going to walk through the different types of sexual disorders, the therapies that actually help, and specific medications so you can fully understand your symptoms and your options. Here is our agenda for today. We'll start with the types of sexual disorders, move into psychological and behavioral therapies, review medical and pharmacological treatments, and finally, point you towards some resources for further exploration. Section 1. Types of sexual disorders, defining the clinical presentations. To put your mind at ease right off the bat, research tells us that about 43% of women in the United States experience some form of sexual difficulty. Think about that for a second. That is almost half. So if you're dealing with this, you are far from alone. Many women suffer in silence, but these are very, very common experiences. Now, as doctors, we only make a formal diagnosis when these symptoms cause you personal distress and have lasted for a minimum of 6 months. A very common diagnosis we see is female sexual interest/arousal disorder, or FS8. Now, this diagnosis actually merges desire and arousal into one category. Why? Well, in practice, a woman's desire and her physical arousal are just so closely linked, and they don't always happen in a strict step-by-step order. Depending on your specific experience, you might feel a lack of mental desire, maybe a lack of physical response, or a combination of both. Next, we have female orgasmic disorder, which can present in two distinct ways. It can be what we call primary, meaning a woman has never experienced an orgasm in her life, or it can be acquired, meaning the difficulty developed later on. This acquired form is often due to new medical conditions, changes in medication, or even just stressful life events and relationship challenges. Understanding exactly when the issue started really helps us tailor the right treatment for you. The third major category is genitopelvic pain/penetration disorder, or GPPD. This condition covers both painful intercourse and involuntary muscle spasms. In a clinical setting, we see that these two issues are highly linked. When a woman anticipates pain, the pelvic floor muscles often involuntarily tighten up to protect her. But unfortunately, that tightening causes even more pain. Breaking this cycle is a huge part of what we do in treatment. Moving on to Section 2, psychological and behavioral therapies, non-pharmacological interventions. Because sexual health involves your body, your hormones, and your mind, managing it often requires a real team approach. As a psychiatrist, I frequently collaborate with gynecologists, physical therapists, and pain specialists. We do this to make sure we're looking at the whole picture, addressing every physical and emotional part of your health, rather than just zooming in on one single symptom. It's all connected. Psychological therapies are highly effective here. Cognitive behavioral therapy, or CBT, helps you identify and change those negative thought patterns or performance anxiety that might be actively blocking your arousal. On top of that, mindfulness-based cognitive therapy teaches you to gently focus on your body's present moment sensations without any judgment. This non-judgmental focus actually lowers your stress hormones like cortisol and can greatly improve your physical response and your ability to enjoy intimacy. For patients experiencing pain disorders, we often combine those psychological therapies with pelvic floor physical therapy. A specialized physical therapist can gently guide you through using vaginal dilators and biofeedback. These are very standard, safe, and effective ways to help train those pelvic muscles to relax and alleviate that pain. It definitely takes patience, but many women find a lot of relief through these guided exercises. Which brings us to Section 3, medical and pharmacological treatments, evidence-based pathways. When we start discussing medications, your menopausal status is a huge deciding factor. Before menopause, treatments typically target the brain's chemicals, or neurotransmitters, to help stimulate desire. But after menopause, treatments shift. They focus much more on your body's changing tissues, like vaginal dryness, and the shifting hormones that can make intimacy uncomfortable. Reviewing the core pharmacological options, there are FDA-approved choices like flibanserin and bremelanotide for low sexual desire and ospemifene for the pain associated with menopause. But we also use off-label treatments that have strong clinical evidence. For instance, if a common SSRI antidepressant is causing your dysfunction, we might prescribe medications like bupropion or even sildenafil to counteract those side effects and help restore your normal response. Another important off-label option is testosterone therapy. Now, while it's not formally FDA approved for female sexual dysfunction, clinical guidelines from major medical societies strongly support the use of transdermal testosterone, like patches or creams, for postmenopausal women who are struggling with a sudden, distressing drop in sexual desire. When it's monitored correctly by your doctor, this can be a very helpful piece of the puzzle. Of course, as a physician, I always have to weigh the benefits of these medications against their safety profiles. Flibanserin carries a strict boxed warning for severe low blood pressure, meaning you have to heavily limit alcohol. Bromelatoid can cause transient blood pressure increases and nausea, and ospemifene carries a boxed warning regarding endometrial thickening and requires monitoring for unusual bleeding. We will always discuss these safety profiles carefully before starting any new treatment, making sure you feel completely comfortable with your care plan. Finally, Section 4. Resources for further exploration. Next steps in care. I highly encourage you to consult reputable professional societies for more information. Organizations like the International Society for the Study of Women's Sexual Health, the American College of Obstetricians and Gynecologists, the Sexual Medicine Society of North America, and the North American Menopause Society. They provide excellent, evidence-based articles, screening tools, and directories to help you find specialized care teams near you. Honestly, finding a clinician who really specializes in these disorders makes a world of difference. So reflecting on all of this information, consider what aspects of your own journey you should bring up to your doctor. Remember, you do not have to just live with this distress. Based on this clinical roadmap, what specific symptoms or concerns are you ready to discuss at your next healthcare appointment so we can help you find relief? You deserve to feel comfortable, heard, and supported in your sexual health.